You hear me?
Good day.
Good evening.
Can you hear me,
Good
Rohan?
morning. I hear you.
Okay, we start in 25 minutes, okay?
Okay, sure. Yes. It was supposed to be 7 p.m.
Yeah. And what?
I still okay. We can
Yeah.
start in 25.
No, we start. Yeah, it was scheduled, but the first speaker's coming late. This happens a lot.
So I will join in 25 minutes if that is okay.
Oh, okay. Hold on. Are you on car? Can you get in okay?
I yeah, I'll join in 20 minutes.
Okay,
I'll join in 20
come
minutes.
into the Zoom link, okay?
Yeah, yes,
Get
yes.
off the
Same
WhatsApp.
link. Same link. Yeah.
Get off the WhatsApp and come on the
Okay, so I will join in 20 minutes.
You would just say 10 minutes?
I'll join in 20 minutes.
Okay. Hello, Dr. Khan.
Hello, sir.
How you doing?
I'm good. How are you?
Very good.
I'll go first if the other participants have not joined.
Yeah. Let's see here. Because I can't stop. We got to leave. Okay, let's start now, okay? Because I'm pressed for time. I got to leave early.
Okay, okay.
Okay, let's ready to start. You got your camera working?
Yeah,
Okay, yeah, 10,
I'll
9.
share my screen.
Okay, I don't see your face. You need to turn on your camera.
Yeah, just
Okay, good. Okay, here we go. 10, 9, 8, 7, 6. Good morning. This is Dr. John Bennett broadcasting from the home of Neurosurgical TV. Today we are broadcasting the Neurosurgery Aspirants, and the first lecture is Dr. Umaya Khan, a pathologist from India, and she's going to talk about neurodegenerative disease and epilepsy. It's all yours, Dr. Khan.
hello, good evening, everyone. My topic for today is neurodegenerative diseases and epilepsy. So I'll be starting with the introduction to neurodegenerative diseases. Neurodegenerative diseases occur due to progressive neuronal loss with selective vulnerability. That is to some of the neurons are vulnerable to the damage. More like they are more sensitive. And the neuronal damage occur by either protein misfolding or mitochondrial dysfunction or oxidative stress, impaired autophagy, or excitotoxicity, or neuroinflammation. All these leads to this tau protein formation, misfolded protein. These all are tau protein, alpha synuclein, and PRP are the misfolded proteins, and due to oxidative stress, all this leads to accumulation and neurodegenerative diseases. Tau protein accumulation causes the Alzheimer's and frontotemporal dementia. A beta protein accumulation causes the Alzheimer's disease. And so in Alzheimer's disease, we see the tau protein and A beta. And in Parkinson's disease and Lewy body dementia, we see the alpha synuclein deposition. And in ALS and frontotemporal lobar degeneration, we see the TDP43 protein deposition. And when comes to the Alzheimer's disease, it is the most common cause of neurodegenerative disease. Um, and it leads to it occurs because of A beta plaques in the extracellular deposition and tau tangles, which are the intracellular deposition, and this leads to neuronal loss and hippocampal atrophy. Here we can see that there is a image of the cerebral hemisphere. This side is the healthy brain, and this side is the cerebral atrophy occurs in the Alzheimer's disease, neurodegenerative disease, ventricular enlargement and volume loss, sulcal widening, hippocampal atrophy, and the cortical thinning. Um just a second. Yeah. Coming to the histopathology of the Alzheimer's disease, it occurs due to, as we have discussed, that the plaque formation. These are called the senile plaques. Here we can see in the image where consist of A beta core and dystrophic neurites. Neurites are the part of the neurons, and as here we can see that the A beta core, and also there are these neurofibrillary tangles which are called the tau proteins. We can see here this dark color cells which are the tau um proteins, and also in the Alzheimer's we can see that there will be amyloid angiopathy and cortical atrophy. Stains, we can study this histopathology by either congruent staining, as in the amyloid angiopathy, which highlights the amyloid deposition, and and we can see that the amyloid protein A beta and phospho tau protein we can study by IHC. Now coming to Parkinson's disease. Parkinson's disease is again, next neurodegenerative disorder, which clinical features will be resting tremors, bradykinesia, rigidity, and postural instability. And we can see in this, we can see in the gross image, there will be loss of substantia nigra. This is the normal image of the here substantia nigra. Here it is the normal, and here there is a loss of substantia nigra. This pigment is lost here. And in histopathology, we see there will be Lewy bodies which consist of alpha synuclein. This is Lewy body, and it consists of alpha synuclein protein. Lewy body in the substantia nigra region in the brain of Parkinson's disease. As we can see here, this is the IHC image highlighting that Lewy body. And next we come to the Huntington's disease. It is a autosomal dominant disease, and it occurs because of this CAG repeat. CAG is a sequence in the DNA repeat sequence in the CAG repeat sequences occur in the Huntington's disease gene, which is present on the chromosome number 4. And clinical features in the Huntington's disease will be chorea, behavioral changes, and dementia. In Huntington's disease, we can see in the gross image here, this is a normal brain, and in Huntington's, we can see that there is atrophy, cerebral atrophy, and due to the cerebral atrophy, these ventricles gets enlarged, and there will also be a basal ganglial atrophy. And in microscopy, we see this as a neuronal loss. The neurons will get lost due to the cerebral atrophy, and there will be reactive astrocytes surrounding these neurons. Here we can see that the intranuclear, this is the nucleus and this is the intranuclear inclusions in the cytoplasmic granules, and here there are neuritic aggregates. These. Now coming to the amyotrophic lateral sclerosis, this is leads to both upper motor neuron and lower motor neuron degeneration. And here we can see that there is normal spinal cord, and this is the ALS. Here there undergoes the atrophy of this spinal cord nerve roots. Here, this leads to fasciculations and spasticity. In the histopathology, we can see that these are the inclusions, which we call it as Bunina bodies, and these are the motor neurons, which with a small eosinophilic granular and intra cytoplasmic inclusions. This is the histopathology image, and this is the IHC image, which is highlighting the intracytoplasmic inclusions. Next, we come to the prions disease, which is rapidly progressive dementia, myoclonus, and causes the spongiform change without inflammation. An example of prions disease is the Creutzfeldt-Jakob disease variants of CJD and Kuru. Histopathology, we see that there is spongiform change here and vacuolations, neuronal loss, and in reaction to this, there will be reactive astrocytosis. As we can see that this astrocytes surrounding these neurons have increased. And in IHC, we can see that the PRP plaque formation this is the IHC image, which is highlighting dark brown as a PRP plaques. Diagnostic tools in the prions disease is EEG, which shows periodic sharp wave complexes. And as there is a neuronal degeneration, this 14-3-3 protein leaks into the CSF, and that we can detect into the CSF by biochemical analysis. And other investigation is the MRI. Now we come to the frontotemporal lobar degeneration. This is also another degenerative disease of the brain, which causes early behavioral and language changes in the individual, and it occurs comparatively in younger individuals than the Alzheimer's disease. In the gross image, we can see here that the frontal and temporal lobe shows the atrophy here. This is the normal, and this is the dementia patient with the cerebral atrophy. And this have frontotemporal lobar degeneration tau protein, which have PIX bodies. These inclusions here we call it as PIX bodies and TDP43 inclusions. And this is the IHC immunohistochemistry highlighting the same proteins here. Now we come to epilepsy. Epilepsy is also one of the important subject in the neurosurgery. So I have decided to take it in little bit detail. So I'll just go through the important points in the epilepsy. What are these? So epilepsy, by definition, it is a recurrent unprovoked seizure, and the causes are generally genetic, structural, or infections, or either trauma. And there are different types of epilepsy, which is either focal or generalized or unknown onset. And there I have listed some like causes of epilepsy, genetic causes like channelopathies, idiopathic epilepsy syndromes, structure like cortical dysplasia, hippocampal sclerosis, stroke, tumors, and infections like neurocysticercosis, viral encephalitis, TB, meningitis, and traumatic due to head injury, metabolic hypoglycemia, hyponatremia, immune causes like autoimmune encephalitis, and some unknown causes. Now there are some epileptogenic lesions which we should know. What is the basic pathology behind it? So I'll just explain the three major things, so which is the focal cortical dysplasia, mesial temporal sclerosis, and low-grade tumors. These are the epileptogenic lesions, and vascular malformations also can cause the epilepsy. Now we can, like, I'll explain a few points about mesial temporal sclerosis. It occurs like due to hippocampal sclerosis and gliosis, and there will be neuronal loss in the C1A or CA3 react, and there will be reactive astrocytosis surrounding it. And in the MRI, we can see here as a atrophy, and there is hyperintensity. Now we come to the focal cortical dysplasia. This is a localized malformation of the cortical development causing epilepsy. There will be cortex in the brain which is like aligned properly. There are 5 layers in the brain which are aligned like very properly. Then if there is any dysplasia in the alignment of the cerebral layers, then there will be and this epileptic disorder. So this is the localized malformation of the cortical development which causes the epilepsy, and in etiology will be developmental anomaly during the neurogenesis. There will be some anomaly during the development. Clinical features will be focal seizures. Often it is drug resistant because it is a developmental disorder. It is onset is childhood. It presents early or adolescent, and it has variable neurological deficits. Now there is a classification of this focal cortical dysplasia. The type 1 focal cortical dysplasia is just cortical dyslamination. The cortex in the brain, which is aligned properly, there is some misalignment, which we call it as cortical dyslamination. Then type 2 is there will be dyslamination, and along with the dyslamination, there will be dysmorphic neurons. And this dysmorphic neuron presented like along with the balloon cells. Either balloon cells will be present or absent. Then it is type 3. Type 3 is associated with another lesion like tumor or sclerosis, like that. In MRI, we can see the general features of this thing is focal cortical dysplasia. There will be blurring of the gray-white matter junction, and with abnormal architecture of the subcortical layer. In T2 flare, we can see here that hyperintensity white matter without transmembrane transmantle sign, and abnormal circle or gyral pattern. Now we come to the histopathology of the focal cortical dysplasia. There will be cortical disorganization. See, there we have seen the normal images of the brain, normal cortical images of histopathology. But here we can see that the disalignment of this neuron, arrangement of this neuron, some haphazardly arranged neurons here, which are not aligned properly, which is called cortical disorganization. And in type 2A, we see the dysmorphic neurons also. The neurons which are some abnormal neurons with some abnormal development will be there in the type 2A, and type 2B. In type 2B, there will be dysmorphic neurons, and along with that, these balloon cells. As we can see here, these cells look like a balloon, so we call it as balloon cells. And this we can study with the special IHC markers like NEUN highlights the neurofilament, NEUN neurons, and neurofilament also highlights the dysmorphic neurons, and vimentin, and this is the vimentin and CD34 here, which highlights the balloon cells. So now we come to the summary of the neurodegenerative diseases and epilepsy. Neurodegenerative diseases occurs due to protein aggregation and misfolded protein aggregation and selective neuronal loss, which is the hallmark of neurodegenerative diseases. And the common neurodegenerative diseases are Alzheimer's disease, Parkinson's disease, Huntington's disease, and amyotrophic lateral sclerosis. In epilepsy, is major cause of epilepsy is focal cortical dysplasia or mesial temporal sclerosis. And we also can see the histology and IHC are the crucial for diagnosis of these lesions. Thank you.
Okay, very good. Thank you very much, Umaya.
Thank you, sir.
And not good. Welcome, Romain. Welcome, Omkar, and welcome, Sakshai. You know, I have one question. It's not really. I'm not a neurosurgeon, first of all, but I'm wondering how much AI is affecting pathology. Very quickly, it's affecting pathology. AI.
Yeah, it's affecting very in a positive way, because when we detect the this thing lesions and the mitosis, the necrosis, and the AI is like it's still under the research, and we are trying it whether but it is good. There are some articles which I have came across that it is affecting to like impactable level.
Okay, that's interesting. Well, okay, I'm sorry we're pressed with time, and I appreciate your spending the time to present. And we'll hopefully see you maybe next week. We'll let you know if we're going to have it next week, okay?
Yeah.
Okay. You have anything to say? You have something to say?
This was my fourth lecture, and then the tumors I'll take after some break.
Yeah, of course.
Yeah.
You have
So
a 2-week vacation.
thank
Have
you.
have a good time.
Thank you.
Okay, let me introduce Omkar Pal. We're running short on time because of my poor organization. He's going to present on etiopathogenesis, diagnosis, and management of raised ICP. Welcome, Omkar.
Okay.
Thank you, sir. So, shall I start now?
Yeah, sure. Remember, we're short here, short on time.
Okay, so in the meanwhile, I'll just introduce him again. Dr. Omkar is a final
Hey,
year medical student.
we're not seeing the screen yet. You're not sharing the screen.
Yeah,
Okay, there you are. There you are.
okay.
Okay, you're all
Yeah.
set.
Yeah. So, my topic was etiopathogenesis and management of raised intracranial pressure with special reference to Indian scenario. So, yeah, Dr. Rohan was saying something. I interrupted in any way. So, if you wish to continue, you can. But anyway, so
Okay,
myself,
so
Dr. Omkar, yeah.
yes. Yeah, please continue, Dr. Omkar. Sorry, go ahead.
Go ahead.
So myself, Dr. Omkar Pal, I am the final year student in Institute of Postgraduate Medical Research and Institute, and I had been the anatomy prospector and the class assistant of pathology and pharmacology in our college. I had been the member of IASSS and Royal College of Physicians as a medical student. And so this is my small presentation, and thanks to Dr. John that he gave me this opportunity to present. Anyway, so let's not waste time in this. And so My topic is in raised intracranial pressure. So, in definition, by definition, intracranial pressure means pressure in the cranial wall. It includes the brain tissue, CSF, and blood, both the arterial and venous part. And so I will not first and start with this normal ICP waveform. They say that there are three parts with the percussion wave, tidal wave, and dichrotic wave, where the percussion wave represents the intracranial arterial pulsation and P2 represents the rebound in brain tissue elastance. And if we look minutely, there are some observations of 5 minute dichrotic notches, amongst which between P2 and P3 there is a small dichrotic notch represent also simulating the dichrotic notch in arterial pulse. Normal arterial ICP in adults is 7 to 15 millimeter of mercury, though there has been some studies of Sauna Walker, and so on, and they have been demonstrating some others like up to 20 or maybe 22. We'll be coming to that soon. So these are the common list of causes of raised ICP. Traumatic causes of brain injury in India, about it's 1,16,000, and it resulted in death of 50% of cases around. So beyond that, the traumatic causes, there are cerebral edema, which is vasculogenic and cytogenic, though I will be coming to that both are similar in sense and we can't distinguish between them. There is change in due to blood volume. There is defective autoregulation, cerebral venous thrombosis, arterial malformation. It later on results in other changes too, and there is changes in CSF mainly due to hydrocephalus. There is obstructive and communicating type. Increase in CSF production, choroid plexus papilloma. This is rarely found in our college. Also, a study was made by Professor Shamadar. It was published, and there it was the incidence is very rare. Unknown is idiopathic intracranial hypertension, also termed as pseudotumor cerebri, and hydrocephalus. The obstructive causes may be lesion in ventricles, ventricular wall. Lesion may be distant from ventricles with mass effect. Communicating are post-hemorrhagic subarachnoid hemorrhage, raised CSF due to infection, and raised CSF proteins. Meningitis can cause both increase in CSF production and it can also cause cerebral edema. So the point that was discussing that even some researchers, Reiner stated that both vasculogenic and cytogenic are of similar kind, because when we talk of cytogenic, the cytogenic often does those also come from the vasculogenic part, and those effects from the vasculogenic origin only. Now here's the diagram that I may be not so much good in drawing diagrams, but this is I constructed this of myself. So this is the flow of CSF, and we'll study as we go on that different parts and obstruction that we deal upon in production and absorption of CSF. Produces from the choroid plexus of lateral ventricle, then it goes through the foramen of Monroe of third ventricle to aqueduct to Sylvius, fourth ventricle, the foramen of Luschka Magendie, and then subarachnoid space through superior sagittal sinus. It goes on for absorption. Now, for communicating hydrocephalus, this is an important and interesting topic. I found that even our teacher was discussing regarding this water hammer in intracranial compliance. Soon we'll be dealing with the compliance of intracranial, but here in this case, it is found that this circuitry of the hydrocephalus or the flowing of CSF has been found in a resistance-like pattern, like series and parallel communication. So, like if the intracranial compliance reduces, it gives a water hammer kind of effect, and this causes increase in subarachnoid pulsation, and that leads to the enlargement of the ventricles. So yeah, this was one of the researches made on idiopathic intracranial hypertension. So in this case, we found that empty cellular findings we can found it. So this is mainly found in case of females. Ratio is 5:1. It is found mostly in multigravity states, and in pulmonary arterial hypertension may also be found. And the ideal findings are found on the superior border of the pituitary, and different fluid intensities that is reflected in CT, and of course it occurs due to this subcellular variation and migration of arachnoid membrane. Causes in Indian context. high incidence of traumatic brain injury. It is due to poor road safety enforcement, neuro infections, tubercular meningitis. Yeah, it has a high incidence. And neurocysticercosis, Japanese encephalitis is growing nowadays. It is a re-emergent disease in our locality. Delayed healthcare as access in rural areas, late referrals, increase in the rate of hemorrhagic stroke from uncontrolled hypertension. So yeah, this was also a research made in our college regarding the relation of BMI with the intracranial hypertension. So there is some positive correlation, also a certain kind of corollary that was found regarding the YY paradox. That although that Indians may have that kind of BMI maybe less than 25, however, their abdominal circumference and like central obesity is much more, so that should be considered regarding the adipocyte and adiponectin circulation. That may be a positive element. Now, the pathophysiology, it results from the disruption of blood-brain barrier in vasogenic edema. Cytotoxic edema results from cellular injury, impaired autoregulatory mechanisms. So we can see that, we'll see later on that in case of the normal autoregulatory mechanisms, after certain duration, the compliance reduces and it gives a kind of slope that produces a positive intercept in the x-axis. However, when the autoregulatory mechanism get impaired, the curves become sigmoid. And later on, we'll deal with two kinds of main herniation syndromes. There are central and uncal herniation syndromes. Although we have other types, this uncal tonsillar falcine and central mostly are kind of downward transtentorial herniations. We have upward transtentorial herniations, we have transforaminal herniation, and also upward transterritorial herniations. So in case of central syndrome, we'll see that chain strokes breathing with small pupil. When midbrain gets involved, it shows tachypnea and decerebrate rigidity. When pons get involved, it shows rapid and shallow respiration with respiration with irregular and long shy or gasps when medulla gets involved. Now, uncle syndrome, this occurs due to uncle herniation, the uncus part when gets herniated, it produces a different kind of scenario in the first part and then it merges with the central syndrome. At first, it produces unilateral dilated pupil. Then, when midbrain gets involved, this consciousness gets impaired. So, in the first stage, we'll see that the consciousness remains intact and with clear consciousness appears. And if progresses, it produces extensor plantar reflex, bilateral dilation of pupil, and then it progresses along with the central syndromes and will show similar symptoms. So now we'll deal with clinical features, and it shows the early clinical feature of headache which worsens in the morning. Vomiting with or without nausea, but it is found that without nausea, vomiting is more prominent, more suggestive of raised intracranial pressure with altered sensorium. It shows Cushing yeah. Cushing's triad, which shows hypertension with bradycardia and irregular respiration, change strokes breathing, and sometimes with some medullary dysfunctions too. Papillary asymmetry or sluggish response is found with cranial nerve palsy, for example, the abducens nerve, and more it produces the stress on the brainstem. It can produce Parinot symptoms, Parinot syndrome like features. It can produce this classical sunsetting syndrome. It is found in mostly in child. This was a picture from our clinic only. And then it goes for motor posturing and decorticate decerebrate rigidity is found. Seizure and coma may also be present. And during seizures of decorticate or decerebrate rigidity, aggressive medication and treatment should be done for better outcomes. Papilledema is also a syndrome which is neither sensitive nor specific. However, if we find this single sole symptoms in case of any patients, should not go unchecked, because even after relief of the intracranial pressure, this continues for a long time, and later on maybe we have to go for optic neural shift defenestration or something like that. So in diagnostic approach, we have seen that imaging for rapid assessment finds mass effect, hemorrhage, and shapes. MRI is done for diffuse axonal injuries, delayed changes. For diffuse axonal injuries, it is quite difficult to analyze, and even autopsy findings shows only petechial hemorrhages. Yeah, for ICP monitoring indicates if GC is less than 8, even Jaffe found that even if it's less than 6, it is more corroborative. And of course, with the
Okay, all set, Omkar? Okay, I guess he fell off the screen share. He'll be coming back in a sec, hopefully. Omkar, can you hear me? Omkar, well, he fell off. He'll come back. We'll just give him a second. Waiting a second to see if he comes back. Unfortunately, sometimes the Wi-Fi in the hospitals aren't too consistent, depending upon how many people are using the network. And maybe prime time in India there, wherever he's at. He looked like he was in the hospital, so I imagine it's a academic YouTube channel. Typically, their Wi-Fi, and that's subject to the user. There he's back. Okay, go on. Carry on, Amkar.
sorry for the interruption, and it got tripped.
That's okay. Okay, you got about 10 minutes, okay?
Okay.
I know it's tough signing in when people are watching you. Success.
So yeah, general measures, I will finish it quite soon. General measures is maintaining partial pressure of oxygen greater than 100 millimeter of mercury, saturation greater than 95%, and reducing brain metabolism by analgesia, neuromuscular blockade, and antipyretic medication. Neck is placed in neutral position, and head is anti-flex 30 to 45 degrees. Research was made by Feldman and his colleagues, where it is seen that up to 60 degrees it produces no reflection in cerebral venous flow, and rotation produces a better and prompt response. Tighter glycemic control maintains racial pressure of carbon dioxide at 35 to 40 millimeter of mercury, and seizure prophylaxis, phenytoin is more preferred. SV12 blockers, though administered in our place, but it is not recommended by Brain Trauma Foundation. Nutrition feed the as per this was as per Brain Trauma Foundation guidelines. Nutrition as per feed the person by fifth and at the most by seventh day. Infection prophylaxis, the patient oral care needs to be recommended for ventricular associated disease and antimicrobial impregnated extraventricular drain, and sometimes we use silver impregnated too. The seizure prophylaxis cannot be levetiracetam cannot be prescribed for better response. Management goals, lower the ICP. ICP threshold is normal 5 to 15, intervene at greater than 22. It is 20 to 22, and there are several researches on this. And maintain the cerebral perfusion pressure. The CPP is equal, the difference between mean arterial pressure and intracranial pressure. Target is 60 to 70 millimeter of mercury. And treating the underlying cause for the secondary reasons is the most important and sometimes becomes life saving too. Blood pressure threshold systolic was maintained for 50 to 69 years. It is beyond that 100 millimeter of mercury, and for others it is 110. And for management goals, I have made some criteria regarding this is not rigid but can be flexible. For CSF generated reasons, it can be acetazolamide, external drainage, or internal drainage, that is shunt. For blood related things, it is head elevation, hyperventilation, and barbiturate induced coma. Although this last two has some side effects and some constraints that we'll deal later on. Brain related thing has the CPP management, cerebral perfusion pressure, osmotic agents are mannitol and hypertonic saline, and antihypertensive can be included. Amongst the others, there is surgical evacuation, and most of the hot topic of the day is the decompressive craniotomy. Medical options are osmotherapy, the mannitol up to zero point 0.1 to 0.25 to 1 gram per kg IV can be introduced. And it has been seen that it has some side effects. If it is more than 320 milliosmoles per liter, it is causes renal failure. And for better maintenance of vascular volume and euvolemic rate, the Mengele et al. It has been found that hypertonic saline is more preferred nowadays. So although the old school still follows the mental, but controlled hyperventilation will see that it has some side effects, and we have found that Mozeller has produced some researches where it is seen that moderate dose of hyperventilation produces some temporary effects. So nowadays, the prophylactic hyperventilation of PaCO2 less than 25 millimeter of mercury is not recommended. Barbiturate-induced coma, it is recommended only in case of refractory cases which are refractory to medical and surgical treatment. Steroids is not recommended. Surgical intervention is decompensated craniectomy. It is a bifrontal craniectomy. It's not recommended without a mass lesion or intracranial pressure more than 20 for more than 15 minutes within an hour, refractory to medical therapy. And in these cases, it is seen that Brain Trauma Foundation itself doesn't have given the proper indications for a decompressive craniectomy. Though we in our place we do primary craniectomy regularly, I think more or less yes. Nowadays it has been reduced due to medications. But secondary craniectomy that has been recommended for late ICP elevation is not in vogue much. A large frontotemporal decompressive craniectomy, yeah, it is better than a small frontotemporal decompressive craniectomy.
Excuse me,
Extraventricular,
Omkar,
yeah,
five more minutes, okay?
okay.
Go ahead, carry on.
So shunts that is produced, there are ventricular peritoneal and ventricular subgaleal shunts, and extraventricular drain extraventriculostomy. I have a video, small video about that, and then indications we'll be dealing now. So these are the shapes of shunt and. So in this case, we'll see that our bar hole has been produced, that we can create a bar hole in the maybe in front of the coronal suture and 3 millimeter, 3 centimeter of the midline. And then when the instrument is introduced, we have seen many of the residents in India, they introduce it and go up to maybe 7 or 8 centimeters deep. And so one thing the gap should be maintained. This is single chip low definition camera used mostly in our places, but we have high definition ones that will start soon. Yeah. So this is the part. Now I'll take 10-second pause and in this. So sometimes it so happens that the ventricle gets enlarged much and the septum is too thin. So but the problem is sometimes we get into the different contralateral ventricle and go beyond that. So the point is when we see that the right thalamus striate is right of the choroid plexus, then we can identify that yes, this is the right ventricle. Then we can visualize in this case the foramen of Monroe, and after that introduction of into the third ventricle will be done. So I have taken it a pause. Then yeah, so after we have skipped the part of third ventricle, I'm having some pictures to show, and due to NFC regulations, I'm going to show it. So during the piercing of the terminal lamina, we'll see that sometimes cautery or forceps are also used, but Fogarty is better in the sense that you don't damage the basilar artery, or that is the best backup. I mean, worst thing that to happen to touch the basilar artery and get pulsation shimmering out of it. And of course, irrigation should not be forgotten at any time. Some of the points to do after proper irrigation and after entry, we have to revisit the place and we have to check it for that the pre-pointine space for uh, so never to lateralize. Lateralizing will damage the caudate nucleus because it all passes through there. And so these are the pictures that we have taken regarding the aqueductal stenosis. So we can see this is the foramen of Monroe. One thing we should clearly note that if the mammillary body and the fornixes are not yet to be not to be damaged, then we should make one thing clear that bar hole, if it is not visible, the anatomical structures, we should come out and do it once again more. Because other than that, we can damage mammillary body, even the fornices in front, and there is possibility that anterior nucleus of thalamus may also get damaged. On both sides, we are having third neuron that can get damaged. So these are the parts that we view on the third ventricle regarding fornix, anterior commissural, lamina terminalis, and optic asthma. We have a better view and diagram about that. Now, regarding this optic asthma and the infundibular recess that we found in the rear view, posterior, this is the rear view, posterior commissure, pineal recess, and then having in the rear. Yeah.
Okay, we need
So
to
this
wrap
is the
it up.
part
Need
that
to wrap it up,
we make the incision.
We need to wrap it up, please.
1 minute more.
Yeah, sure.
Progress and innovations of India. Ayushman Bharat is providing emergency and tertiary care access, deployment of mobile CT units in undeserved regions, and teleneuropathy consultations, preventive strategies, road enforcement. This one, robotics, I still haven't done.
Okay. Okay, you're gonna stop screen sharing?
No.
Yeah, I'm sorry to rush you off, but unfortunately, due to my poor planning,
Yeah.
let me see here. Okay, screen sharing, stop share. Yeah, okay, thank you very much, Oka. I'm sorry to rush you. But thank you for preparing. Thank you for taking the time, and we'll have you on more often. I'll be talking to you, and just any questions, just let me know. Okay.
Okay.
Thank you very much. Thank you, Dr. Khan, and thank everyone else. I'm sorry, I gotta go.